Let's study about anti-tubercular drugs. These are grouped into first line drugs and second line drugs. First line drugs are the drugs which are having high anti-tubercular efficacy, low toxicity, and can be used routinely. Drugs that are involved in first line are isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. Most commonly, drugs used as first line are isoniazid, rifampicin, pyrazinamide, and ethambutol. Isoniazid is represented with the letter H, rifampicin with R, pyrazinamide with Z, and ethambutol with E. Second line drugs are having low anti-tubercular efficacy and higher toxicity. So that's why they are used when first line drug cannot be used or to supplement them. Drugs that are involved in second line of therapy are fluoroquinolones, which are orally given, and there are other oral drugs and some of the injectable drugs. Fluoroquinolones such as ofloxacin, levofloxacin, moxifloxacin, and ciprofloxacin are used. Other oral drugs like ethionamide, prothionamide, cycloserine, terazidone, para-amino salicylic acid, rifabutine, and rifapentine are used. Injectable drugs which are given are kanamycin, amikacin, and capreomycin. Let's see the hierarchy in efficacy or the priority according to which we use the drugs. First priority is given to first line oral drugs HRZE. Next priority is given to injectable drugs. Next priority is given to fluoroquinolones, and the next priority is given to second line oral drugs, and the final the newer drugs such as bedaquiline, clarithromycin, clofazimine, linezolid, coamoxiclav, imipenem, and celestine. These are used as reserve drugs for extensive drug resistance TB, and they are not used for MDR TB. Let's study about first line drugs. First is isoniazid. Isoniazid chemical name is isonicotinic acid hydrazide and is represented with the letter H. Isoniazid is bactericidal, and in bactericidal it acts on fast multiplying organism and quiescent ones are inhibited only. They act both on intracellular and extracellular TB. They are equally active in acidic and basic medium. What is the mechanism of action of isoniazid? It inhibits the synthesis of mycolic acid. The gene responsible for mycolic acid synthesis is INHA and KSA, and these genes are the targets for isoniazid. Isoniazid enters into cell of bacilli, tubercular bacilli, where it converts into reactive metabolite by the enzyme catalase peroxidase enzyme. This reactive metabolites adduct with NAD and inhibit the mycolic acid synthesizing gene. This reactive metabolite combine with NADP also and inhibit mycobacterial DHFRAs. This will result in interruption of DNA synthesis. How isoniazid resistance is produced? It is due to mutation of catalase peroxidase gene, that is CATG gene, and this type of resistance can be overcome. This type of resistance cannot be overcome by stopping isoniazid. Next, resistance is due to INHA gene mutation, and it can be overcome by high dose of isoniazid. Next, resistance may be due to isoniazid efflux from bacterial cells. So there are three criteria by which there is presence of isoniazid resistance. First is mutation of catalase peroxidase gene. Next is INHA gene mutation, and next is efflux from bacterial cell. What is the pharmacokinetic of isoniazid? First is it is completely absorbed orally and penetrates all body tissues, tubercular cavities, placenta, and meninges. It is extensively metabolized by liver by N-acetylation by NAT2. It is extensively metabolized by liver through N-acetylation by NAT2, and this acetylated metabolite excreted in urine. According to gene variation, there are fast acetylators and some of them are slow acetylators. The fast acetylators people are, in these people, the biweekly regimen will be less effective, and in slow acetylators, isoniazid induced peripheral neuritis is more common. There is production of hypotoxic minor metabolite by CYP2E1 from acetylhydrazine. What are the adverse effects? There are dose dependent toxic effects like peripheral neuritis, paresthesia, numbness, mental disturbances, and rarely convulsions. These dose dependent toxic effects is due to interference with production of active coenzyme pyridoxal phosphate from pyridoxine and its increased excretion in urine. So, for prophylaxis, we will give pyridoxine along with isoniazid as a dose of 10 mg per day, and these are given in diabetics, chronic alcoholics, malnourished people, pregnant women, lactating women, and in AIDS patients. For isoniazid neurotoxicity, the treatment is pyridoxine 100 mg per day. The other adverse effect is hepatitis, which is more common in older people and in alcoholics because in chronic alcoholism there is induction of CYP2E1 which will generate the hepatotoxic metabolites. After the first sign of hepatotoxic, we will stop the drug so that the changes can be reversible. The other adverse effects are lethargy, rashes, mild anemia, and arthralgia. Next drug is rifampicin. Rifampicin is a bactericidal drug. It acts best on slowly or intermittently dividing tubercular bacilli. These can act on both extracellular and intracellular bacilli. Mechanism of action is this interrupts RNA synthesis by binding to beta subunit of DNA dependent RNA polymerase and blocking its polymerizing function. DNA dependent RNA polymerase of Mycobacterium is encoded by RPOB gene. The rifampicin resistance is produced by mutation in RPOB gene. Pharmacokinetics of rifampicin is it is well absorbed orally, its bioavailability is 70%, food decrease its absorption, so taken on empty stomach. It is widely distributed in body, it penetrates intracellularly and enters tubercular cavities also, caseous masses and placenta. Though rifampin crosses meninges, but it is largely pumped out from CNS by P glycoprotein. It is metabolized by liver by converting them into active deacetylated metabolites which will excreted in bile and some in urine. Adverse effects of rifampin are hepatitis, which are dose related and are mainly present in pre existing liver disease patients. It is infrequent with dose more than 600 mg per day. If there is development of jaundice on giving rifampin, we will stop the drug and the changes are reversible. Minor reaction. So, in these reactions, we do not stop rifampin. So these reactions are cutaneous, like flushing, pruritus plus rash, especially on face and scalp. Next is redness and watering of eyes. Next symptoms are flu-like symptoms like chills, fever, headache, malaise and bone pain. Next are abdominal cramps, nausea, vomiting and diarrhea. In some of the patient, there can be urine and secretions, orange red color, and this is harmless. There are some serious and rare reactions like purpura, hemolysis, shock, and renal failure. Other uses of rifampin are leprosy, prophylaxis of meningococcal and H. influenzae, meningitis, and carrier state. Second and third choice drug for MRSA, diphtheroids, and Legionella infections. Combination of doxycycline and rifampin is the first line therapy for brucellosis. Next drug is pyrazinamide. Pyrazinamide is bactericidal, is weaker than isoniazid, more active in acidic medium, more lethal to intracellular bacilli and to those at site showing an inflammatory response. And these are more active at these states because there is acidic medium. Next is they are highly effective during the first 2 months of therapy when inflammatory changes are present. These act by killing the residual intracellular bacilli, so it has good sterilizing activity. Pyrazinamide duration of treatment is shortened, risk of relapse decreased. The benefits of using pyrazinamide in antitubercular therapy is duration of treatment is shortened and there is a risk of relapse is decreased. What is the mechanism of action? Mechanism of action is pyrazinamide enters into tubercular bacilli where it is converted into pyrazonic acid, which is the active metabolite of pyrazinamide. It will inhibit the mycolic acid synthesis and disrupt mycobacterial cell membrane and its transport function. The resistance of pyrazinamide will develop due to when it is used alone or due to PNCA gene mutation. Pharmacokinetics of pyrazinamide is it is absorbed orally, widely distributed and has good penetration in CSF, and it is highly useful in meningeal TB. Metabolized by liver and excreted in urine. What are the adverse effects? Hepatotoxicity, hyperuricemia, and some of the other side effects. Hepatotoxicity is dose related side effect. It is more common in Western countries and is less common in Indians. So we give a daily dose of 25 to 30 mg per kg to prevent the incidence of hepatotoxicity. It is contraindicated in patients with liver disease and is safer during pregnancy. It can cause hyperuricemia, which is a more common side effect of pyrazinamide. Due to hyperuricemia, they can be gout. Hyperuricemia is due to inhibition of uric acid secretion by kidney tubules. The frequent side effects of Pyrazinamide are abdominal distress and arthralgia. Some of the other side effects are flushing, rashes, fever, and loss of diabetes control. That's why there is a need of repeated blood glucose monitoring. Next drug is ethambutol. It is tuberculostatic drug. It is also active against MAC and other mycobacteria. It is fast multiplying. It acts mainly on fast multiplying bacillus. It is used with rifampicin, isoniazid, and pyrazinamide to hasten the rate of sputum conversion and to prevent the development of resistance. The mechanism of action of ethambutol is it inhibits arabinosyl transferases, which is involved in arabinogalactan synthesis, resulting in interfering with mycolic acid incorporation in mycobacterial cell wall. Its resistance is due to mutation in MBB gene. Pharmacokinetics is 3/4 of oral dose is absorbed, out of which half of is metabolized and is excreted in urine by glomerular filtration, tubular secretion, and some are excreted in feces. These are cautiously used in renal disease patients. Adverse effects are retrobulbar neuritis, which is dose and duration dependent side effect. In retrobulbar neuritis, there will be loss of visual activity, loss of visual acuity, color vision, and field defects. It will result in stop the drug if there is first sign of visual disturbance. We will stop the drug. Other side effects are nausea, rashes, fever, and rarely peripheral neuritis. It is safe during pregnancy. Next is streptomycin. This is a tuberculocidal drug. It is less effective than isoniazid and rifampicin. It acts only on extracellular bacilli because there is poor penetration into cells, so it can't act on intracellular bacilli. There is poor action in acidic medium. It penetrates the tubercular cavities but doesn't cross the CSF. It is used as supplemental first line drug because it has high toxicity and is given as intramuscular injection. Toxicity such as ototoxicity and nephrotoxicity, maximum we can give this drug for 2 months. Thank you for watching and subscribe my channel for more updates.